Good afternoon and welcome. I'm Justine Kane, the Group CEO of Diabetes Australia, and I'd like to welcome you to the last of our National Diabetes Week Great Debate series. This afternoon, we are going to be discussing issues that have arisen around technology-driven healthcare in Australia. The big question is Australia falling behind? Are we keeping pace with other countries in terms of diabetes treatment and diabetes tech? I'd like to acknowledge the traditional owners of all the lands on which we meet and pay my respects to elders past and present. Diabetes Australia is committed to improving health outcomes for all Aboriginal and Torres Strait Islander people affected by diabetes and those at risk. I'd like to warmly welcome all of our participants on the panel today. Natalie Wisher, OAM, and a very new OAM, so congratulations, Nat, CEO for the National Association of Diabetes Centres, or NADC. Natalie has extensive management experience in clinical and executive health roles across a range of healthcare settings. Her core focus is to improve diabetes care and the support of people living with diabetes in Australia. Cheryl Steele is a registered nurse with a postgraduate qualification in midwifery, health counselling and diabetes education. She is the manager of the Diabetes Education Services at Western Health. Her primary interests in diabetes education are insulin pumps, CGMs or continued glucose monitoring systems, and diabetes in pregnancy. David Burren lives with type 1 diabetes and writes a blog, The Bionic Wookie, about living with medical technology. Dr. Mary Abram is a clinician from the Rio Tinto Children's Diabetes Centre and Perth Children's Hospital. In 2022, she was awarded the prestigious ADS, or Australian Diabetes Society, Boudinot Rising Star Award in type 1 diabetes. She is studying the use of oral insulin. And last but certainly not least, Amanda Bartlett is a registered nurse and midwife with over 38 years' experience in health. She has been a credentialed diabetes educator for over 15 years and specialises in type 1 diabetes, pregnancy and technology. Amanda is a past board member of ADIPS and is an honorary fellow at the University of Technology in Sydney and also the current president of the Australian Diabetes Educators Association. I'd also like to warmly welcome a number of people who are online, the chair of the Diabetes Australia Board, Dr. Michael Stanford, and a number of our state CEOs, including Caroline Wells, Rowan Clifford, Sue Hawes, and Glenn Noonan. Glenn is the CEO of Diabetes Victoria, who is a member organisation with Diabetes Australia. One of the key themes of this week has been around just how quickly medical research is transforming and how this is truly revolutionising how we treat and manage diabetes via new medicines and new technologies. But while many Australians living with all types of diabetes can access a wide range of products to help them manage their condition, some people are still missing out. It's truly essential that our health system keeps pace with assessments and subsidies for the latest medicines and technologies so that all people living with diabetes can experience the considerable benefits. So I'm going to open our panel discussion now. And Nat, I'm going to go to you first. So this is a very broad question to start off our debate. Is Australia doing enough to ensure Australians can access technology quickly and equitably?
Great question. Thanks, Justine. Having had a passion for diabetes and technology for perhaps the last 15 years, stemming from living in arguably some of the most remote services in Australia or centres in Australia, and living rurally myself for many years, I believe in technology. I think it really can be an absolutely hugely beneficial adjunct to supporting people with chronic diseases, but particularly diabetes. It isn't for everyone, but it is an important tool. What I've found travelling to international meetings over the last 10 years is that when I go to those meetings, I'm always really surprised with what technology they have and what technology we don't have. And when you go to a meeting and you see that they're up to number 7 and we've got number 2 in Australia, we're not keeping up. And I think that's the bit that bothers me the most. And I've thought long and hard about it and where the stops are within our system. And I think Australia, we should be really proud that we do healthcare particularly well when you see many other overseas first world countries. But we also become quite protective, and our models for ensuring the rigour around the safety of our technology is really good, but sometimes that slows down the process of allowing the latest technology to come into Australia. So sorry for the long answer. I think
Great.
we do have access to technology, but perhaps not as quickly as it's made available. And I think the government subsidies are really important. I look forward to talking about that next.
Yeah, definitely. And we're going to get to that. So thank you. So let's talk about some of the positive things that we're seeing. Mary, I'm going to come to you. You're a paediatric endocrinologist at Perth Children's Hospital. I'd really like to hear how diabetes technology is improving the lives of kids. So how it's helping their treatment and helping their families. You're on mute. There we go. That's good. Oh.
No, yeah.
There we go. Mary, I'll just repeat the question.
On now. So just to repeat that question, it was essentially around technology, how it has developed in the due course of time. And for me, especially as a pediatric endocrinologist in this field over the last decade especially, what I have seen is a big, massive, palpable, visible change. And type 1 diabetes is not just the child, as we all know, it is the whole family. It's not just about glucose levels, it is also about the sleep, the quality of life. And unfortunately, although our focus remains around glucose levels, technology has given that brought about that change. We have so much relied on blood glucose monitoring, record books, testing overnight, and all that has shifted so dramatically that when we see families, it's about the quality of sleep, the ability to get back into work, which is so important for the parent, and also just normalizing type 1 diabetes. That has changed. What I can see, that has been a big change, a big shift over the last 10 years. From a technology perspective, we as a center have significantly adopted technology, as in we have got a big uptake of pumps and CGM. To close to 90% of our children are on CGM for type 1 diabetes. We also have got a big pump uptake, 50 to 60%, and the number previously was constant, but with closed loop systems, that's gone up again. So there's clearly a change in adoption of technology as well over a period of time. So maybe from being less than 5% of CGM use to sitting at 90% CGM use, that's 10 years gap. We were 30% pump use, we are now 60% pump use. So that's essentially technology pretty much in our clinic as pumps and CGM. And also the entire interface about the various apps that are used for manage, that is also a constant upgrade and improvement with every whatever comes into the market, essentially. So it has caused a big change, and I'm really glad to see. And whenever we counsel families, when they first come to their new diagnosis in the hospital, say this is a different time from what it used to be 10 years back. So just giving that sort of reassurance that they are not alone and we can support them through this improved diabetes journey is a big thing for us as clinicians when we see these families.
Yeah, thanks, Mary. It clearly makes significant differences for people. Sleep quality, as you said, ability to work, kids' lives, able to get to school, all of those sorts of things. Cheryl, I'm interested to hear from you about what you find are the greatest benefits in your working day around technology.
Oh, my working day and technology. Well, I don't think in the introduction you disclosed that I do live with type 1 diabetes. I'm a 38-year veteran, and without my pump and my CGM and my automated insulin delivery system, I would not struggle, I don't think, in the workplace, because there's always an answer if you look hard enough, but it certainly makes it easier. Like, I can accept to give this presentation at 12:30 without panicking that's my usual lunchtime, because I know my automated insulin delivery system is going to make allowances for me. So I guess it allows me to participate in the workplace on an equal footing with anybody else, to not feel different because of my diabetes. I'm well past retirement age, as you probably would have guessed, but I'm still working full time because I love it. I have a passion for it. I'm still healthy. And yeah, so technology has made a huge difference. And every time something new comes out, I'm the quintessential N=1 experiment to see if I think it's going to work for other people. But just because it works for me doesn't mean that it's going to work for other people. And I am very fortunate that I am working and I have an income that allows me to take out private health insurance, so I can have an insulin pump. And the CGM subsidy has made it more affordable for me to have CGM. And that's an area that I hope we will cover for those people who can't afford private health insurance, why they can't access the latest technology.
Yeah. Thanks, Cheryl. Very powerfully said. And David, as a very early adopter of technology and someone who lives on the cutting edge of technology, I know is a big passion of yours. What are the biggest impacts that for you? Let's talk personally first, if that's okay. Personally, what are the biggest positive impacts for you that you find from diabetes technology? You're on mute. Sorry.
I swore I wasn't going to get caught out by that. So I've lived with diabetes for about 40 years now, and I started using a pump in about 12, 13 years ago. And then it took a while for CGMs to come along, and then things accelerated 2017, 2018. And the technology now it makes life so much easier than it used to be. I'm using fairly advanced things now, but I wake up in the morning and I look at my blood glucose. I go and have breakfast. I get on with my day. I have lunch. I get on with my day. And at some point during the day, I'm going to change my cannula, make sure the pump is still running. Things are maybe change my sensor that day when a little alarm goes off. But that's about it. Not having to even count carbs or announce food or bolus, because it's all completely automatic on my system. I'm living at the extreme. Now, the commercial systems are starting to gain some of those things. There's been the first system overseas, the islet pump has come out, which says you don't have to carb count, but you do still have to tell us when you're eating food. So things are moving that way. So these features are going to come along. But when you get to that stage, it's life-changing. It's almost as though you don't have diabetes. No, you do know you have diabetes. If you run around too much, you're going to go low. You're going to have some food on hand. But it's so much different from when I would have to keep tracking everything in my head. How much am I eating? What am I exercising? How much have I dosed? It takes all of that stuff away. And my clinical results are now, well, so much better than they were. And one of my doctors keeps using the words normoglycemic, trying to compare me to a normal person. A normal person, I keep saying, I am normal. I'm my normal. So the technology can do lots of things, and that makes up the pumps, the insulins, the CGM, the control systems that tie them together. Like Cheryl said, I'm lucky in that I have private health insurance, so I can access a pump. I have type 1 diabetes, so I can access a CGM. And there are lots of people with type 2 and other types of diabetes who can't access that stuff at the moment because they don't have the subsidy. And it's a huge market, and there's all this commercial issue that if we gave it to everyone, then we wouldn't be able to afford it as a country, whatever. Some people say that. May or may not be true. Trying to get technology to people so that more people get benefit is part of the trick of this whole thing. And the way it's tied in with the companies, we're a little country on the other side of the world from many people. So we're dependent on companies being able to make money and selling stuff here, because otherwise they won't. They might have a great fancy product that's going to improve our lives, but they're commercial entities. We need to convince them that it's worth their time to come to us. So all of these issues cross over and interact with each other. The technology itself can do amazing things.
Yeah, thanks, David. So if I may, I've got two follow-up questions for both you and Cheryl. So we know that stigma is a very real issue for people living with diabetes. I'm really interested in whether you have seen a change in the stigma that you've experienced or discrimination as you're using technology, in public settings, etc. Has that had a positive or a negative impact or no change at all with regard to utilising technology and how people that you may or may not know interact with you?
I'll go first. I remember times when I was injecting insulin with syringes and then with pens. And I'd usually go off to the toilets or somewhere private to have my injection. And then I eventually got to the stage I'd do it in a restaurant. I'd just try and be subtle so I wasn't upsetting people unnecessarily, but I wasn't ashamed of it. But all of that changed a bit when I got an insulin pump, and it was just a device I could pull out of my pocket, press a few buttons and put it away. So I could dose without having to worry about all those things. There were still times that I had someone say to me, will you stop playing with your phone? I'm not playing with my phone. It's not my pager. It's my pump. I'm giving myself some insulin for this food that we're having. And these days, I just look at my watch and I get on, and no one actually has to know that I have diabetes or I'm using devices. So it's all hidden away these days. The pump itself is under my clothes. No one can see it.
Thanks, David. Cheryl, yep.
Yeah, I would concur now with insulin pumps and CGM. It's not always obvious that you're dosing. Same thing, I'd get out my phone and nobody knows whether I'm playing Candy Crush on Facebook or giving a dose of insulin. So in that manner, it's very discreet. I do remember many, many years ago, because I also have children with diabetes, and when my daughter was 5, we were sitting up in a restaurant and I was drawing up, no pens back then, I was drawing up insulin out of a vial to give her dose of insulin for her meal, and there were people staring at us quite openly, and my daughter said to me, Mummy, what are they staring at? And I said, I've no idea, Dale. I don't know, we're just doing our thing. And I tried very hard to bring my children up with that attitude. For them, diabetes is just normal. And both of them are now adults, and, they don't feel they're different because they have diabetes. But I think a lot of that is the way they were raised. You've got to keep reinforcing positive messages and make them feel that for them, this is normal. And,
Oh, I think we've had Cheryl drop out for us.
Oh, can you hear me?
Yes, you're back.
Yep. Yeah, I was going to say, I guess my health professional hat says you can't make diabetes a burden where people feel it's something extra they have to carry around with them. It's easier if you can incorporate it into your life and it's just you. It's not something extra. And in my workplace, I work with a bunch of endocrinologists and diabetes educators. So, I've always said, look, if I really get sick, send me somewhere where they don't know me, just in case they want to get rid of me on the sly. But look, you do still find prejudice. I've just been engaged in a quite lengthy conversation with somebody here at the hospital who wanted me to advertise for a diabetic nurse rather than a clinical nurse consultant who was a diabetes educator, and they couldn't understand why I was upset about having to advertise for a diabetic nurse. And I said, do you know how many nurses actually have diabetes? And they had no idea what I was talking about. So there is still stigma out there. There is still the wrong language being used. And I think we do have a long way to go, because even if in health professional settings you're having to explain to people why you're not the diabetic nurse, even though you might have diabetes, but we still have a long way to go.
Yeah. Thank you, Cheryl, and thank you, David. I'm just going to pivot to Amanda. Is that what you're hearing resonating from your experiences over the last 15 years, that technology is in some ways having a positive influence and impact on stigma and discrimination?
Yes and no. Listening to David talk is so inspirational. And I think we know that people that live with diabetes, it's all about reducing the burden and the headspace, and listening to you sort of waking up and just glancing at your watch is inspirational. And I really want that to be available for all people. I think technology has revolutionised diabetes, there's no doubt about that, but the impact on health professionals is very high. For us to come up to speed, for us to be able to support people well is really important. Devices are incredibly varied, and at times you could get it over the shelf, at times it's subsidised for some people living with diabetes, not all, but everyone living with diabetes has a right and should be referred to a credentialed diabetes educator for a detailed discussion around which device is best for them and which is going to support them best. Now, we've talked a little bit about cost. So just to kind of summarise it, if you live with type 1 diabetes in Australia, it's around maybe $2,500 per annum to access continuous monitoring and an insulin pump. And we're grateful to the Albanese government for supporting that. But if you live with type 2 diabetes, type 3C diabetes or cystic fibrosis, it's going to cost you maybe around $8,000 per annum to access an insulin pump and continuous monitoring, plus your medications, plus your visits to a healthcare professional, plus your private health insurance. And that is out of reach for so many Australians. Justine, you're muted.
Okay, I'm not going to go on mute again. Thank you. It's a really good segue into the question that I was going to ask Natalie. So it's really well. Natalie, what are some of the barriers to accessing diabetes technology that you're most concerned about?
Gosh, how long have we got? Probably.
And how do you think you could overcome them? What do you think we need to do?
Oh, gosh, that's a huge question. Thanks, Justine, for adding that bit. Look, I think we've talked about price. I think that's the biggest burden. I mean, we have over 1.5 million people living with type 2 diabetes, over 130,000 living with type 1 diabetes. Subsidies of insulin pumps and continuous glucose monitors are the only way that we can fully support people to manage diabetes in the best way possible, reduce their risk of complications, reduce their HbA1c and give them longevity as a person without diabetes. We have a real challenge in Australia because we've not only got this price differential, which then talks about class differential and, socioeconomic. But we also have challenges with people living in rural and remote areas being able to access a workforce that are able to support people utilising their technology. So that's a real challenge. Then if you conversely look at tertiary level hospitals that have a workforce that are able to support people, they can't keep up with the varying technologies, and also remuneration of healthcare professionals to support people using technologies isn't available. So whether it be someone in private practice or someone working in a tertiary level hospital, that remuneration to look and interpret all of the data they're now getting from people using devices, and to then turn around and not only provide some information about how to interpret that data, but also education that empowers the person living with diabetes on how to use that information for themselves to improve their care. So I think, Justine, I I probably haven't even touched the sides of this discussion, and I think everyone here on the panel can add to it, but they're just some top-level responses front of mind.
Yeah, no, that's fantastic. And I might throw back to David. This is a bit of a curly one, David. So talking about last night we were talking about diabetes remission, and there was a great conversation around the value of CGM and biofeedback mechanisms. We know that there is insufficient workforce currently to be able to support the number of people living with diabetes. If we add additional technology in, that problem's going to get even greater. What do you think AI could do in this situation if we got to a point where we did have more access and subsidies for CGM as an example? We know that, and Amanda and I talk about this quite frequently, the amount of data coming in is just so much, and the pressure on the healthcare profession is huge. Do you think AI has a role to play in the future here, and are we seeing anything internationally emerging, David?
I know there are people working on analysis tools using AI and other stuff, trying to interpret patterns. There are some simple things that some friends have put together that you feed it some of the graphs out of your CGM reports, and it will come up with some advice of things to talk with your doctor about next time you see them. And that's at a very simplistic level, it's essentially just working off some of the graphics. There is more work being done in that, but I think a lot of the tools that we have at the moment can help people with what we've got. If you have a CGM, you have a graph that comes out. It shows you're going up, you're going down. It's actually useful to look at the patterns over days. There are tools, Dexcom Clarity, some of the LibreView things, where you can look at some of the patterns over previous weeks. Teaching people how to access, that those tools are there, how to access them, rather than just giving them the raw product and in a box and say, here you go. I think that will help accelerate the uptake without necessarily needing a linear growth in the HCP resource requirements. So more and more tools are going to come in terms of smart analysis. There are lots of tools available now in terms of analysis that many people just don't think to look at. So I think further work is needed in both those areas. I'm not aware of anything magical like ChatGPT that is going to answer all your questions about your diabetes CGM patterns at the moment, but I'm sure someone is working on it.
Yeah, and very aspirational. Cheryl, back to you. So if we were able to get more subsidies up and going, what groups would you be prioritising first?
I think first would be women with gestational diabetes. When you work with women with gestational diabetes, you have a very short time to make a difference before you're going to affect the outcome of that child that's going to be born. And there's lots of research now that tells us that children of mothers with GDM that aren't well controlled are children who are likely to develop obesity and type 2 diabetes later. So, when we talk about preventing type 2 diabetes, we've got to start thinking about it while the child's still in the womb. By the time they've been born, it's, and they're used to having high insulin levels, etc., because they've been fed a high glucose diet into uterine. We're already running behind the 8 ball. So I would say first, if we could get increased subsidy, it would be for women with GDM who are on insulin. And I know here at our centre, we have about 2,000 women a year with gestational diabetes, and about 60% of those women end up on insulin. So CGM would be a huge benefit to them. So that would be my number one extra if we could have it. And then I think people with type 2 diabetes who are on insulin would probably be the next group, because anybody who's on insulin has increased risk of hypos, etc. So being able to avoid hypoglycemia would make a huge difference to the person living with diabetes, but also just nationally to the health budget. We have people coming into hospital who've had falls and they fracture a hip because they're older and they've had a hypo and they've fallen. So, there's lots of benefits that could be had by that. So they would be my next two if I could have who else could get CGM subsidised.
Right. And Mary, how does that sit with you? What do you think about those prioritisations?
Clearly, obviously, there is much more to be done from the adult sectors, and we are quite in a very comfortable zone from a pediatric perspective with the availability of CGM for type 1s. But I do have to mention about our type 2 adolescents, especially who have type, who are just newly diagnosed with type 2. This is a condition which is very unlike a late onset type 2, which is very well known to be rapidly progressing and aggressive. And these adolescents, these children who are diagnosed quite early on, do bear the brunt of complications later on in life. This group is highly vulnerable, and we don't really have any subsidy for these children. Just not even if it's not, even if they're not on insulin, it does provide them a therapeutic intervention to learn from what the food spikes can be related to. So it is even just a behavior change that can be introduced by CGM. And that behavior change can go long run in improving their lifestyle, just engaging in more activity. So I think it has got a big, powerful place. It doesn't need to be worn 24/7 like how for type 1s. We are even fine with intermittent CGMs, but definitely that's a group that we would like to highlight, that there is a need from a pediatric perspective, because healthy child later on would be a healthy adult. So essentially just getting CGM to that group for at least in my sector, that would be very beneficial. And just to add on to it, considering the benefits from what CGM can provide in type 2 in a pediatric setup, we have accessed funds from the hospital, and we have started using CGM locally for our patients. And that is because we can't really wait till the subsidy comes through. And we think we have to be proactive if we can, from whatever resources we can get, local grant supports that we can access. So yes, we find that's a need, and we have started making changes. But I think for us, yes, as a community, as a nation, much more needs to be done.
Right, thanks, Mary. Matt, jump in.
Yeah, sorry, I'm busting to say something. But having come back from the European Conference on Diabetes and Technology earlier in the year, there's some really new emerging evidence around the benefits of using continuous glucose monitors or flash monitors for behaviour change tools, and finding, as Mary said, that they don't need to be worn 24 hours a day, 7 days a week. Even a week here and a week there, or a couple of weeks, really help that cycle of understanding, oh, I exercised, gee, look what happens to my blood glucose levels. Oh, I ate, this, and they went, shot up. And there was even a study in the US where they presented some information whereby they put two groups into one that had a lot of education and one that didn't, and they put them on flash glucose monitoring for 2 weeks. Even the group that wasn't provided with a whole lot of education, as long as they knew how to read the blood glucose levels, they actually changed their behaviour. So I think that's going to be something that we're going to talk about at our technology meeting coming up in August, and I think it's a really important new area of diabetes technology use.
The hot topic from across every debate that we've had, this issue has come up. So, Amanda, anything you wanted to add before we move on to our next area?
I think what I'd really like to add is when I saw CGM being rolled out, how many kits ended up in cupboards not used. So the government had subsidised, and it was because it wasn't educated properly. So when you think about CGM and alarms, and we've heard a lot about sleep interruption from Mary and from David, it's really important that any form of device that is given to a person living with diabetes is educated well by a CDE so that we can minimise alarms and we can teach for safety. And Natalie, I agree that, you know, you can use it for behavioural change, but I'd still say that it should really be rolled out with a CDE in place for safety and for better outcomes.
Thanks, Amanda.
Completely agree, Amanda. I was just pointing out that, I think from a behaviour change perspective, I mean, the arm that had support and education did better. That was obvious, but yeah, thank you.
Good discussion. David, so many people online with us here today would be familiar with the hashtag We Are Not Waiting. You're someone who's living proof of that hashtag, and you keep a keen eye on what's going on internationally. So what are we waiting for in Australia? What should we not be waiting for? What should we be continually advocating for? And, you know, we are not waiting.
Okay. I mentioned before we were waiting due to a number of reasons. And there's a bunch of areas of technology that we can look at. So there's little things like the insulin pens. Novo has just brought out a Novo Pen 6 that has a memory of all the doses that you give and can upload it to a phone. They haven't actually brought out the software to actually upload it to, so we're still waiting on that. There is some We Are Not Waiting software that will talk to them already, so not all of us have to wait, but most people are dependent on the commercial suppliers. There are devices like that in the works that have been out overseas for a while, and they're gradually coming here. We have the insulins themselves. So the faster insulins make it easier for the automated insulin delivery systems to react faster. And there's evidence starting to build up that, yes, it can improve things by having the faster insulin. And there's some still trials that are going at the moment to actually firm that up. Some of the tricky stuff with that is some people have looked at the clinical trial results and say, there was no difference in the HbA1c of the people who had the faster insulin, but they weren't measuring how free they were with their food. They were able to eat a lot more freely. So evidence that pulls together a lot of that will, I think, increase some of the pressure for us to have access to the faster insulins. We have FIAS. We have all this drama at the moment with FIAS going away, and partly that's this problem with pricing and a single supplier, and we're on the other end of the world. There's all sorts of issues going on there. Hopefully that's going to be resolved, but there is a faster insulin than FIAS. There's a thing called Leongev, which is not available in Australia yet. Your doctor can't tell you about it because it's not a medically approved thing through the TGA yet, but it exists overseas, and it's an accelerated form of Humalog. It's even faster. We're waiting on the company to apply for approval, and them applying for approval, they're probably only going to do that if they think they're going to make money. All of this comes together. The CGMs, there's the Libre CGMs. Libre 3 has been out overseas for several years. I don't know exactly when that might be coming to Australia. There are future versions of that which are being worked on at the moment. They're not products yet, but I've seen data from some trials that also report on ketones at the same time. So there's exciting stuff there, but I don't know how long that's going to take to get to Australia, even when it comes out overseas. The insulin pumps, still on the CGMs, there's the Dexcom G7, hasn't made it to Australia yet. Personally, I'm not especially fussed because G7 works great. G7 also works great. It has some advantages, but also has a few disadvantages. I don't think we're too bad with G6, but that's just me. There's the Eversense implanted CGM, so it just goes under your skin, and the next version I think is once a year you have a little implant that's changed. And the people I know overseas who are using that love it compared to the other things. No sign of it here. Again, we're a little market. I mentioned the iLet the iLet pump from Beta Bionics, the one that says you just have to announce that you're having a small, medium, or large meal, and it'll deal with everything else. There's new pumps coming out from various companies. Tandem have just brought out a new, smaller version of their pump, and that's now got approval in the US. And I know that lots of people in the Australian community are going to start asking, why don't we have it here yet? And it's, well, they don't actually have it on the streets in the US yet. So a lot of people see stuff overseas and expect, why don't we have it here now? It's always going to take a little bit of time, but then it takes years for some of these things to come through, and that can be frustrating.
And thank you, David. And Amanda, I'm sure you sit there thinking this is fantastic for all Australians living with diabetes to help, improve their quality of their life. But I imagine that you also sit there with a little bit of concern about how is the workforce going to cope with this? How are you financially going to manage in terms of subsidies? So let's go there. Let's have a bit of a chat around credentialed diabetes educators and what you see the gaps are at the moment in how our workforce is subsidised and supported.
Well, we know that our workforce is smaller than, it's not adequate to support people living with diabetes. So we, ADEA, are advocating for more positions in hospitals, where we had the joint submission to Parliament with DA and ADS looking for more subsidies for credentialed diabetes educators. So currently, if you live with diabetes, you'll get 5 visits per year with all allied health professionals, and it's just not enough when you're living with a chronic disease. The subsidy is $58 to the person, so people in private practice will only ever get 5 visits per annum. And it's if you want to put someone on an insulin pump, those 5 visits are gone immediately. So that's insufficient. I think what is great, and the one thing for me that came out of COVID was that, we can now do telehealth. So when we're thinking about regional remote communities, we can actually they can access care with us in major cities. So if we have skills around education, we can use telehealth, but it's still not enough visits. The tertiary hospitals, community care also don't have enough credentialed diabetes educators. So ADDA did put together 5 scholarships last year and 3 scholarships this year for Indigenous students, and we're mentoring them end to end to try to get appropriate care out to Indigenous communities as well. And that's an area that's completely lacking with the highest rates of diabetes in the world.
Thanks, Amanda. And Mary, what are your thoughts on workforce? And I mean, how do the hospital staff cope with dealing with new technologies coming in, say, to emergency rooms and then more generally across the hospital?
It is a fairly challenging space. It is not just the hospital system, but even with new technologies being rolled out, it's the entire staff who needs to be upskilled. That includes the doctors, the educators, the dietitians, the terminologies around the various software, the interaction or certain blocks with the hospital firewalls and all that. So it's just very challenging. It's a step by step. And we do feel the frustrations in the healthcare system when we have to navigate these issues. And then what we have tried to develop is try to put something like a technology team, because at least something like a go-to person or people, a multidisciplinary team, so then we can support the rest of the staff to sort of come and upskill, provide or create the resources. So that's how we have tried to navigate it. It's not a perfect solution because we can't expect the entire staff to learn on their own, upskill on their own. So it's just establishing a smaller group, which is the go-to place to create and even start technology in these patients, even to provide them the subsequent visits. It's really run by a particular team, and then we hand over those children, the families, to the broader team. It just helps our workflow, but it is something which we then find difficult when these families present to the hospitals or different hospitals who are just not clear about how to use pumps or CGMs, and we have heard a lot of frustrations from families and even from the doctors, because the truth is healthcare professionals who don't deal with diabetes don't have that clinical expertise to provide the knowledge. So then there is the distrust that happens between their GPs or the ED doctors or the hospital system, and it's just a friction that happens. Have we been able to navigate that? The answer is we've just tried a lot of education support at various in the emergency departments, the wards, but it's a work in progress. We just have got new staff who come onto the wards, and then we just have got this, ongoing issue. So no, we haven't got this perfect. We are still struggling, and I just don't see a good way to deal with it at the moment, apart from educating or providing those in-service ward educations on a regular basis. But it's not a perfect solution. We do struggle with this, and I can say from even a health care professional doctor's perspective as well, when new systems come through, upskilling is definitely a task, and it does bring up a lot of sitting with the patient in the room, and we're forgetting our passwords. We've got 3 different platforms. It is challenging. So it just brings up, although it is great, it does come up, it opens up a whole can of worms, which we try to navigate. We'll say, we'll do this better with the next clinic visit. And I think we are doing better, but lots needs to be done. And I think we're all singing the same song with the need for technology support, not just the devices, but the education, the staff support. Everything is just on the go at the moment. We're just learning on the go, and there's much more to be done there.
Thank you, Miriam, and I agree. Lots of nods, and I'm sure everybody online is nodding as well. So a question to any panelist: is there any country that is doing the health professional education really well?
I don't think so. I think everywhere has its challenges, because not only is it about learning the new systems and teaching patients to self-manage those systems. That's always my goal, I guess, is not to make people dependent on us for their technology, but to teach them to self-manage so they don't have to always come back to the health professional. But I see in some countries an awful lot of waste of technology because patients aren't supported properly to go on it. They don't have the benefit of a diabetes educator who can set them up and teach them how to do all those skills. So they get frustrated and it goes in a drawer. And you think, there's probably $8,000 worth of equipment that isn't being effectively used. So I think in Australia, despite all our shortcomings, we still do pretty well. We have, I've done much the same as what Mary's done, have a small number of my team who specialise in the different technologies to do this and help them make that decision. And they're the ones that do the initiating and the follow-up clinics that we have, but we try and rotate all our doctors through that, which sometimes for the patients is frustrating because, you go, every time I go to the clinic, there's a different doctor. And you've got to try and explain, well, you're trying to teach those doctors about the technology because next time that doctor might be in the emergency department when they turn up. And so it's to their advantage. And that's what happens in a teaching hospital. We're always teaching, which I have to add is another passion of mine, is teaching other health professionals. And, to have the knowledge and not share it, it's not worth having the knowledge. So I think we should be very proud of what we do with what we've got. There definitely needs to be more. And I agree that, I work in the public system. So, I'm always badgering to try and get more staff, trying to come up with creative ways to write business cases that, people who know nothing about diabetes might be impressed by. For those in private practice, those 5 visits, I can tell you as a person who lives with type 1 diabetes, my 5 visits all go to the podiatrist because I like somebody else to cut my toenails. for me. If I needed to go and see a dietitian or a diabetes educator, I'd have to pay because I've used up all my 5 visits. So I think for particularly people with type 1 and technology, they do need more access visits to a credentialed diabetes educator to make them safe and to make sure that huge investment that the government's making in that technology is actually utilised to the best of the person's ability. So that's my bit.
And I just wanted to add to that what Cheryl said, and to add to Mary's point. In Australia, and what David said before, we're a very small country, so sometimes we're not of interest to device-making companies and tech companies because we're too small a market. So the return on investment for the amount of time that they've got to spend to get a device through the TGA may not be worth it for them. Conversely, though, because we are such a small country, we can do things quite well nationwide. And I think healthcare professional education, learning from each other, I mean, that's what we're driven for, our organisation at NADC. We're driving to support centres and services learn from each other. We don't want people reinventing the wheel and saying, oh, we found this great way of doing something, but we're not going to tell anyone. We want that to be shared. And I did a list recently of all the resources out there for healthcare professionals, no matter whether they were CDEs, endos, or they were working in an aged care setting and service. And I have to say, I was blown away with how many resources are available for free through the NDSS, Diabetes Australia, ADEA, through all the entities, including my organisation, NADC, the Australian Diabetes Society. They're all doing webinars. Most of them are for free. Most of them are recorded and available. And I think it comes back down to reimbursement of healthcare professional time. We all know that we do a lot, as Cheryl said, for free, out of hours, and don't take appropriate remuneration for that because we're passionate. But if we're going to get a broader expanse of the workforce upskilled in diabetes care, we need to support them to do these, undertake the education that's actually already been developed.
Thanks, Nat. Now, we're getting close to time, and I've got a Q&A question coming through. Now, I'm going to throw to you, David, and I know that everyone's going to want to jump in and start answering this question. So I'm going to go to David first, then we'll do a quick round the grounds as our final question opportunity. So, David, why isn't Australia at the cutting edge of technology? Why can't we have the subsidies, and why can't we get the access, like other countries, to the most up-to-date modern technologies that are available to get best quality of life for people?
We are better off than a lot of other countries. A lot of places don't have a CGM subsidy, for example, for type 1. And it's all dependent on you having the right insurance because that's all that's available. Or they do have a national system and there's like one device available and you get no choice, no option. And I think we're in a better position than many countries in terms of that. Unless the technology is developed here or somehow co-developed here, then we're not likely to be the first ones in the world to get it. So we're always going to be a little bit behind. And it's all a matter of how far behind we are, which is a matter of how complex it is for the companies to get it here in terms of all the administration and the approval process. So I would like to think that we're not far behind in some areas. Sometimes it's actually an advantage for other people to get the new technology first because they find all the problems. That might just be trying to justify things after the fact, but I've seen a lot of problems happen overseas and not be an issue here because we already knew how to deal with the new CGM when it came in, for example. I'm not sure how else to answer the question.
No, that's a really good answer, and I think it's a really, really important point that in lots of ways, Australia is world leading. We have an amazing National Diabetes Services Scheme. We have very supportive governments over many different terms of government, and there is lots of really good stuff that is going on. and we hear from a number of you on the panel with lived experience that you are getting access to what you need. What else, just as a final comment from each of the panelists, because I can't believe this time has gone so quickly, if there was one more thing that you would like us as a community to be considering, and we know that no one knows diabetes better than a person who lives with diabetes, you all either live with diabetes or interact every single day with the diabetes community. What is the one thing that you would like us to be doing more?
I'll answer. I think one thing I would love, both as a person who lives with type 1, as a mother of now grown up kids with type 1, as a grandmother of an adolescent with type 1, and as a health professional who spends all my time working with people with diabetes, I would like us to have the choice of having different pumps with different CGMs, and they all upload into the same platform. You know, if you choose a particular brand of pump, you have to have that brand of CGM. Why? Why can't it be opened up? Because if I find that particular CGM suits me best, or somebody else finds a different one, you know, David and I might have completely different needs as we measure them ourselves. Why should we be forced to do that? I think companies, if they want our business, need to work harder and open it up so that if, you know, you want different stuff, they can go together, and that they could all upload into the same platform, so that as health professionals, you're not having to learn 7 different passwords and 7 different ways of uploading data to be able to give people feedback. So that's my little end.
Thanks, Cheryl. Mary?
For me, again, and I think I just come back to the child who's just newly diagnosed with type 1, and we're introducing technology in that space. Staffing. I think we do struggle with staffing, and I think that definitely is an issue. And B is the support of psychology services, which we haven't really touched based on. But for someone who's really newly diagnosed, and considering that most of the diagnosis happens in children and adolescents period, they do need to live with diabetes, accept technology, and diabetes not just as a stigma, but there's an acceptance. And once that acceptance comes through is only when you can use these devices much more better, optimally, hiding devices, which we spoke about before, and some of those devices sitting in the shelves. It's because there is technology, but there is no acceptance to the technology. We've not been able to have that conversation from an entire mental health perspective around how technology, diabetes, life, everything is connected. We still have a big shortage of psychologists, diabetes educators, and it essentially comes down to staff resourcing and the ability to provide these supports. Because yes, technology is there, but it is not for everyone as well. We see that in our clinics, right? Although there is an uptake, they may not be using it properly. And it is just to identify those barriers and have the discussion. And in a busy clinical time, unfortunately, we are not doing it well. And those are the issues that sort of exponentially increase the risk of disengagement as well, because we are not doing our best, or we can't provide the best in our services. So yes, for me, it does really come down to staffing so that we can support the families adequately.
Thank you. I'll go to Amanda, and then I'll come back to Nat because you're on mute. So Amanda?
I'm going to be cheeky and go for 2. So I'm always going to go for equity of access. I would really love to just see it rolled out and not just be dependent upon private health insurance. I'd like to see all Australians living with diabetes, whether it's type 1, type 2, type 3C, cystic fibrosis related diabetes, be able to access technology. And I'd really like health professionals to be reimbursed for it. We're all passionate. We work with people who live with diabetes 24/7, and we support them 24/7. I'm on call 24/7, looking at data to keep people safe. And I love it, and I do it because I love it. But there needs to be reimbursement to stop burnout. Younger generations won't work like us old people.
Now, Nat, not saying you're an old person. Over to you.
No, I want to support. Yes, I have been burnt out many times in my working life for that very reason. Us as healthcare professionals do give a lot of our time over freely. So that's why I want to say as well, reimbursement for healthcare professionals to use and support people using diabetes technology. So again, just backing up what others have already said, and I'm going to take two as well, which is equity of access, but particularly for our First Nations people. And that would be around having healthcare professionals available and using other technologies like telehealth, like, CGM as a behaviour change tool, all of those resources to support our First Nations people, with 50% of the population over the age of 40 having type 2 diabetes in that population. As someone said before, it's the worst in the world and we need to do something about it.
Thanks, Nat. And David, any final word from you?
I was just going to follow up slightly on what Cheryl said about making systems interoperable. So this all comes down to, as she said, user choice. So some of the devices work better for some people than others. Sometimes it's the cannula type just doesn't suit their skin, or the sensor irritates them or whatever. And some of the companies are happy to work with any device that's made by them, whereas some of the companies will tend to interoperate a little bit more. There is more of that coming overseas. Some of the companies are starting to have devices that talk to each other. But there's always going to be, we're not going to have a lowest common denominator, because we've got this fancy new technology that the lowest common denominator doesn't actually support. So there's always going to be some, it only works with our stuff. But hopefully it'll also work in a more limited capacity with other things, and we get some ability to chop and change, because not everyone is the same.
Great summary. Yes, absolutely. Everyone is an individual. Everyone living with diabetes has unique situations and unique needs. And I know that there is a passionate community of people ready and willing to support and do more every day. That is the end of our debate and the final debate for National Diabetes Week. So I wanted to thank each and every one of you for participating in the panel. I think it's been a fantastic discussion. I wanted to thank the many hundreds of people online and those who have attended all or some of our debates over the last week. You can access all of them online. All of the information that we have received and discussed over the last week will feed into our submission to the Parliamentary Inquiry into Diabetes. And in final summary, I'd like to say thank you to everyone for your generosity of time, generosity of spirit, and for conducting the debates in a really classy way, listening to each other in a respectful manner. We look forward to catching up with you all again soon, and I'm sure next National Diabetes Week we will do something equally exciting. Thank you all very, very much. Bye.